So let's discuss how we're going to manage calls for depressed patients, suicidal patients, behavioral patients. And we usually believe that around the holidays the incidence of these calls increases. Certainly those of us that have been running calls for several years hold that as something to be true. But when you really look at the data, and there's 3 studies here listed with links to go to, it really dispels that myth. But regardless, we need to discuss how we're going to handle these calls. And there's some issues about scene safety, very difficult judgment calls sometimes to make on staging issues. Then consent becomes of a concern. There's law enforcement involvement. And then we want to remind you about some of the confidentiality issues involved with dealing with these types of calls. So anytime we talk about responding to calls for depressed persons or possibly suicidal persons, scene safety is of paramount concern. It always is, but in these cases, some of these calls are difficult to make. The theory is that if a person intends to harm themselves, then what would prevent them from trying to harm us? And so we try to have some guidelines that help you decide how to handle these calls. It's very difficult to make a clear black and white policy because there's so many variables and so many judgment calls that are required. Our risk management method that we use here is that we will risk a little when there's something to be saved. And so the key with this is to determine if there really is an impact that we can make, and therefore we can subject ourselves to some risk, or if really there's nothing for us to do, or what's going to happen has already happened, in which case it would be inappropriate for us to put ourselves at too much risk. So these are difficult, and I don't think you're going to find anywhere a very clear black and white policy on you shall always do this or you shall never do this, and staging is one of those things to talk about. It does require responder judgment. Our safety is our top priority. There are some things we can do for some of these patients. A suicidal patient that has overdosed and has an altered level of consciousness, depressed respiratory drive, can certainly have some need for our services, and we can impact that patient by doing some airway and breathing management things. So even at the BLS level, there are some things that we have to offer these patients, but the difficulty is in determining what's really going on in that scene. And dispatch will do the best they can to obtain information, but they can only give us information that's provided to them. And if the accuracy of the information that they've been given is poor, then bad information is going to be fed back to us, and then we are making judgments on bad information. So we can't totally rely on dispatch to be able to bail us out and to give us a clear-cut, yes, the scene is safe. The scene's never safe, but is the scene safe enough for us to enter? And so this is one of the difficult calls that we run, and would certainly urge folks to make this be a group decision. I think it's very dangerous to enter these calls by yourself, and so scene safety and staging is something that you'll want to discuss with your station members and station leadership at the end of this presentation. We wanted to bring it up now to kind of prime the discussion. So many times you will elect to stage on these sorts of calls and other calls where there's potential violence. And law enforcement may be delayed in some cases. And very busy times or very places that are distant from law enforcement, there may be a delay. And so we may well be there for several minutes, many minutes, prior to law enforcement arrival. It would always be optimal to have law enforcement officers enter the scene first and determine scene safety and determine when it's safe enough for us to enter and assist. But that may not always be the case, and so we don't want to tie your hands completely with that, but we certainly want to emphasize that law enforcement involvement in these calls is necessary, and in many cases the patient's condition is such that a delay of us entering the scene for several minutes is not going to impact the patient care. If we can wait for law enforcement to secure that scene, that's optimal. Whatever you decide to do with staging, that needs to be documented, and that needs to be included in your report. And so the things to document about your decision to stage are when you staged, where you staged, and why you staged. So when you stage is an important thing to note, and in some cases that will be entered in the CAD notes and entered as a time, but it's an excellent idea to also include when you actually staged, and then when law enforcement arrived, and then when you were allowed to enter, and when you made patient contact. So there's several items to keep track of there. And the more you can keep those times consistent with regular CAD times, then that's helpful. Radio transmissions to the communication center should be documented in the notes, and you should be able to access that when you're making your report. Where you stage is also important to document as well as to decide. The purpose of staging is for you to be nearby but not involved in the scene. So if you can be seen from the scene, you're probably not staged in an appropriate place. There's times when that's not possible. There's times when locating the incident because of address issues has caused you to be closer than you would like to be. But document where you decided to stage. But the key thing of all three of these is why you decided to stage. And that needs to be pretty clearly documented, that you did fear for your safety. You did believe, based on information that you were given, that the scene was unreasonably unsafe, not safe enough for you to enter, and that you did need to wait for law enforcement to secure the scene. So document when, where, and why, and carefully describe particularly that why that you elected to stage. The next issue that comes up on these calls is, can these patients refuse? In some cases, and frequently, we're getting these calls second, third, fourth hand. Someone has learned of this patient's intent to hurt themselves, and we're not getting a call directly from the patient. So the patient isn't always interested in seeking transport and medical care. And so this discussion of a refusal or non-consent is important. So we just wanted to remind you of what we consider and what we teach to be the four elements of a valid refusal. And so the first one is particularly key in this case, the legal capacity of the patient. Now, in a case where maybe it's an injury accident and the person is 16 and has minor injuries, then the legal capacity enters into the case then, but usually contact can be made with someone who is responsible for that patient when the patient is a minor and not able to give legal consent. But in these cases with suicidal patients, in many cases law enforcement will determine that the patient doesn't have legal capacity to make a decision, and so the rest of this doesn't even matter if law enforcement's determined that the patient has made a legitimate threat and they've determined that that patient now has lost their legal capacity to make decisions for themselves. Second element of a valid refusal after legal capacity is mental capacity. This is not mental competence. Competence is not decided by medical folks, particularly EMS providers. Mental capacity. And this is a judgment that we make on the patient's ability to process information and understand what's going on. Mental capacity can be decreased or impacted, or a person can fail to have mental capacity to make a decision based on drug, alcohol use, low blood sugar, any of the list of altered mental status. But mental capacity, just by mere fact that the patient has consumed alcohol or has consumed drugs, doesn't negate their mental capacity. A person can have had alcohol to drink or smoked marijuana or smoked crack or any of the other things that people do, and they still retain their mental capacity. It's a judgment call. It's very difficult to make. Things that enter into that decision are the patient's orientation. Are they oriented, fully oriented to their name, date of birth, those sorts of things, to person, place, time, events, what's going on at this point. And it's really the key that we're using. And this requires more than a couple of questions. This requires a conversation, requires the patient to be asked open-ended questions rather than yes-no questions, and to have a conversation with this patient and then A collective judgment of the EMS providers present must be made to determine if this patient has mental capacity. Would urge you to err on the side of caution in the patient's best interest. Many times patients do not have mental capacity, and yet they are able to answer a lot of questions and can do a pretty good job of talking their way out of medical treatment and transport. So if legal capacity is still an issue, if it's not clear that they must be taken for evaluation for their suicidal threat, then the mental capacity becomes the key. And again, probably a collective judgment of EMS providers is better than any one person making that call. And in our situation, we can probably defer to the ALS providers. It is going to be ultimately their call when they arrive from the ambulance services, but they're going to have the same sorts of challenges that we do in terms of assessing mental capacity. The other two elements of a valid refusal after legal and mental capacity are that the patient understands the risks and benefits, and that's more than you being able to say that you told them about the risks and benefits. We need to have a conversation with them and document that to where they speak back to us and they explain back to us that they do understand the risks. And in the case of refusal, they understand the risks, they understand the benefits, and they're simply refusing. They simply don't agree with us that it's the best thing for them to do, but they understand that we think it's the best thing for them to do, to seek treatment, and they understand why we think that is the case. Examples, maybe they have ingested some medication, and we need them to understand that medication, while it hasn't taken effect yet, could take effect after we leave. And so the risk of not being transported could be things as serious as stopped breathing or death. The benefits of being transported would be an evaluation for their medical situation, and in many cases, this is their entry into the mental health system in an attempt to help them work through the reason for their suicidal gesture in the first place. And then for those patients that we are going to allow to stay home, in that they do have legal capacity, they do have mental capacity, and we believe they understand the risks and benefits. They've explained back to us the situation. And even if we don't agree with their decision right now, we've had a conversation and we believe that they're making a decision with all the facts. They also need to know how to change their mind. And when we use the term refusal, that sounds kind of like it's a confrontation with the patient and there's some sort of adversarial relationship, and it's not really the case. It's just our jargon. You may need to explain to them the term of refusal. And so they need to know how to change their mind. What if they decide to seek treatment? What are their options? Well, they can call 911 again, and we'll come back out. They can seek transport by private vehicle with a friend or family or someone and present themselves to an emergency department and seek some assistance that way. So take the time with these patients to both establish their mental capacity, understand that they explain to them and verify that they understand the risks and benefits, and then always leave them with a what are you supposed to do next so that they know that it's okay to call us back. Last thing I wanted to bring up about suicidal patient calls is this issue of confidentiality. And this is a very difficult time for these folks, and while we may perceive that they're seeking attention, and they may well be, that's up to them to seek the attention. We shouldn't assist with that. So our radio traffic needs to be with that in mind. We certainly need to be clear about what the situation is and what resources may be needed and what the safety concerns are. But radio traffic doesn't need to broadcast anything that's particularly personal if we can avoid that. As most of us know, many folks in the community listen to radio scanners. And so when you're speaking on the radio at any time, realize that you're not just speaking to the dispatcher and to other public safety responders. You may be speaking to citizens at large. And so just be mindful of that. Be careful of your radio traffic. Then a lot of times family, friends, neighbors, etc. will will come up to us and want to know what's going on and ask, is everything all right, and those sorts of questions. We need to be careful to to communicate appropriately, particularly with people that are not family and people that the patient has not explicitly indicated to us it's okay if they know information. It's so much better for the patient to tell a family member or a friend or a neighbor or someone what's going on. It's much better for the patient to give patient information than for us to. So we need to be very clear that we don't spread rumors, very clear that we talk to people and give them information that they really need to know, not that they just want to know out of curiosity or concern. So be careful introducing family, friends, neighbors into these sorts of calls, particularly if there's a scene safety issue. The fewer people we have to manage and watch out for, the better it is and the easier it is for us to maintain some cover and some accountability. But in some cases, it is helpful to elicit the assistance of family or friends or neighbors or whoever may be able to help. We just need to be very careful with what we say and use good judgment. And then after the call, of course, in some cases, high-profile cases particularly, we'll be asked by friends, by family, or approached by another member of the public safety community. And just be careful who hears those conversations and what is said. These patients do not deserve to have their very private situation made public in any form, especially if someone approaches you in a Walmart or at a restaurant, or a group of us are having a meal together or in a public setting, and discussion of a call comes up. And it's just be very careful about what we say about these folks. It's hard to put ourselves in the situation of someone who's made a suicidal gesture in many cases, because a lot of us haven't had that experience in our lives, but we should nonetheless try to be very empathetic and try to maintain the confidentiality for these folks. So that's kind of a generality, a general wrap-up of suicidal patients and their management. I didn't want to get into a bunch of stuff about restraint. That's for a separate lesson. But scene safety is paramount for us, difficult to decide in many cases, and documentation of staging and documentation of the incident is critical, and this whole issue of consent and having a conversation with the patient, something that we wanted to reemphasize. So that's the conclusion of our suicidal patient lesson.